hope by the end of the study, you'll have an idea of the answer to this question, which is critical at this point in the history of the world. I'll start with what you all know, that the COVID-19 virus has two pathways, a direct pathway and an indirect pathway toward cardiovascular complications. Direct viral invasion of the myocardium can lead to congestive heart failure and malignant ventricular arrhythmia and sudden cardiac death. Direct invasion of the cardiac vasculature can lead to acute coronary syndromes with acute myocardial injury. The indirect pathway is going to be the major pathway that I want to address this morning, although both pathways will be addressed, but that's obviously due to the immune system's production of a cytokine storm. The oxidative stress caused by the cytokines can be deadly. And it doesn't matter to the myocardium what caused the oxidative stress. In this case, it's COVID-19, but I'm going to show you other clinical scenarios where oxidative stress produces the very same endpoints. So there should be no reason why what I'm about to propose as a very safe, extraordinarily safe way to deal with cardiovascular complications of COVID-19 with no harm to the patient whatsoever, and it can be simply added to what you're already doing so far. The cardiac complications are in patients admitted to the hospital, about 50% have labile blood pressures, 23% congestive heart failure, AFib, 20%, 14% potentially life-threatening arrhythmias. And you don't want to end up in ICU because death rate is about 1% per day for 2 months. So I have an hypothesis. Knowing the patient's sympathetic, parasympathetic, and sympathovagal balance, that's sympathetic divided by parasympathetic tone, sympathovagal balance, is vitally, so the indirect pathway is vitally prognostically and therapeutically important, not only in COVID, because as I said, this is a final common pathway of oxidative stress disturbing the autonomics supply to the myocardium in a way that can be extraordinarily fatal. And so I'm going to have to give you some background information so you can understand the rest of my presentation. In the past, we've only been able to measure heart rate variability directly, forcing assumptions and approximations of sympathetic and parasympathetic tone. But since 2006, and with the commercial availability of the autonomic monitor, we're able to additionally directly measure parasympathetic tone, so that since you have 2 of the 3, you can solve for the third factor in this equation, and now you have an accurate, for the first time ever, you have an accurate assessment of the patient's autonomics. This is all you need, and this is how it works very quickly. You have simultaneously recorded time, frequency, power spectral curves of respiration and heart rate variability. The modal peak of the respiratory activity curve is identified as the fundamental respiratory frequency. Since changes in heart rate variability during respiration are purely parasympathetic, then the new definition of parasympathetic activity is the respiratory frequency area under the heart rate variability curve, contained within a 0.12 hertz wide window centered upon the fundamental respiratory frequency. In this patient, for example, this area in here would have been previously mislabeled sympathetic activity or low frequency area under the curve between 0.04 and 0.15 hertz. Furthermore, this area under the curve would have been inappropriately labeled parasympathetic. So that you can see that prior to 2006, the total heart rate variability was pretty accurate, but the individual contributions of the sympathetic and parasympathetic activities to the total heart rate variability completely inaccurate. So with these accurate measurements, we can obtain some very important clinical data. Firstly, high sympathetic tone, either acutely from COVID or any other acute event, could be an acute coronary event, or chronically elevated sympathetic tone is damaging to the vessels and the myocardium and can result in major adverse cardiac events. On the other hand, low parasympathetic activity is associated with very bad things, but what I want to emphasize is parasympathetic activity is protective against cytokine storms, particularly because it reduces nuclear factor kappa B. This is very, as you all know, it's a very key factor in the multiplication of the immune response. Critically low parasympathetic activity, termed cardiac autonomic neuropathy in diabetics and advanced autonomic dysfunction in non-diabetics, which is less than 0.10 beats per minute squared, has a very, very poor prognosis. So I thought that the ratio of the two, sympathetic divided by parasympathetic, the sympathovagal balance, should have prognostic as well as therapeutic value. So I studied 483 patients over a mean of 4.92 years. As a predictor of MACE, major adverse cardiac event, sympathovagal balance was compared to the Framingham risk score, reversible myocardial perfusion defects, and left ventricular ejection fraction. What we found was sympathovagal balance greater than 2.5 was the best predictor. None of us know the sympathovagal balance of our patients, whether they're COVID or non-COVID, but it's the best predictor of major adverse cardiac events. So now we know two things. We know that a sympathovagal balance greater than 2.5 is a very poor prognostic indicator. And we know that parasympathetic tone less than 0.10 beats per minute squared, whether you term it CAN in diabetics or AAD in non-diabetics, is also a very poor prognostic indicator. So two key numbers. So my questions are, is there anything that we can do about these two key numbers? If so, then will outcomes improve? If they do, the hypothesis will be proven. And my hypothesis is that The indirect pathway primarily disturbs these numbers in COVID. Direct pathway somewhat as well, and we can do something about these numbers, as I'll show you in non-COVID studies that I've already completed. We'll start with diabetes, because hyperglycemic oxidative stress, and you could use COVID-induced cytokine oxidative stress, but hyperglycemic oxidative stress just destroys diabetics' autonomic function, cardiovascular autonomic function. Our alpha-lipoic acid is probably our body's best natural antioxidant. So this is completely harmless. We're all supposed to have our alpha-lipoic acid. Its particularly interesting activity is right here. And that's what we need in COVID-19, among other conditions. So what I did was, in 133 consecutive diabetics who had any abnormality on physiops assessment, were all offered our alpha-lipoic acid. 83 agreed, 50 didn't. Followed their autonomic function over a mean of 6.31 years and recorded sudden cardiac deaths. And this is what I found over a total of a 12-year period: an amazing 43% relative risk reduction in sudden cardiac death in the patients who took RALA versus those who didn't. And it looks like if I'd have kept going further, it would have been even more. Nothing else on earth will do this except an implanted cardiac defibrillator. Nobody in the study qualified for a defibrillator, and only 15% of worldwide sudden cardiac death subjects qualify for a defibrillator. So effectively, there's nothing else on earth that would have done this, and it's completely safe. Why did they die? These are all the people who died versus in both the groups versus all the people who lived, and there are your numbers. Here's the sympathovagal balance greater than 2.5, and here's a 59.5% reduction in parasympathetic activity. So these, looking at all the demographics, everything that I couldn't go into in detail due to time constraints. This was the sole explanation of why these patients died. So we'll pass on this one for the sake of time. And get to the conclusions of the study. Neither the demographics nor the autonomics favored the RALA patients. They just weren't more well. In fact, they were more ill than the controls. The major effect our alpha-lipoic acid had was improving parasympathetic activity. In fact, the only group that improved parasympathetic activity was the group that took alpha-lipoic acid. Even if they died, they still improved their parasympathetic activity somewhat. So that cardiac autonomic neuropathy decreased in 37.5%, of the ALA group that remained alive, but it increased 67% in the group that didn't take ALA and died. The second molecule that I want to talk about in terms of trying to deal with cardiovascular complications of COVID is ranolazine. Ranolazine is remarkable. First, it's remarkable in its safety. It's been out 17 years. There's never been a death attributed to COVID. You just can't give it to class 4, class 5 renal failure patients. Otherwise, it's perfectly safe. And it's unbelievable how good it is in the treatment of, it for angina, but I studied it in congestive heart failure, ventricular arrhythmias. It's unbelievable, which I'll show you. It also has a unique and direct functional effect on the parasympathetic and sympathetic systems. No other drug that I know of for any cardiovascular condition that we treat has a major effect on the autonomic nervous system. So not only is this first in class, but it's first with this effect. And it's also an antioxidant, something we're very interested in COVID, in preventing COVID-19 cytokine storms. So the first study I want to talk about is 109 matched cohort study of completely guideline treated congestive heart failure patients. They were all completely treated. So if our guidelines are complete and we're doing everything we're supposed to do, then when I added ranolazine to half, how much improvement would you expect then? So what we did, we followed their left ventricular ejection fraction, which most of us do in following our congestive heart failure patients for prognostic reasons. We followed their autonomic function as well. This was a 2-year study, mean 2-year study, and we recorded major adverse cardiac events. So what happened? This is the membrane of a ventricular myocyte. This is the fast sodium channel. Sodium, when it opens from 1 to 10 milliseconds, the influx of sodium causes the upstroke of the QRS and the beginning of systole. Any stress, including oxidative stress, produced by cytokines or anything else, will result in phosphorylation of the sodium channel and faulty gating. That will result, let me go back. That will result in what's called failure of gating, and you'll get a late sodium current. I don't know why the animation won't run, but this late sodium current causes the sodium to be exchanged through the sodium calcium exchanger. Now you have too much sodium and too much calcium. This ionic overload severely impairs systole, diastole, microvascular flow, and the sodium and potassium lead to malignant ventricular arrhythmias. So what happened to these patients? Well, when you follow any patient in your practice with serial echoes, you may not know that it takes a change in ejection fraction of at least plus or minus 7 to be statistically significant. 48% of the patients given ranolazine increased their left ventricular ejection fraction by at least 7, 23% by at least 15%. Here's an example. This patient in your practice certainly would be considered for a defibrillator. It would be close to a transplant, but this is a non-ischemic cardiomyopathy. So a non-ischemic situation such as COVID might cause. It can cause ischemia as well, as I showed you. But this was after ranolazine. She felt so well, she stopped taking her ranolazine. So there's no question what ranolazine did. And if you look, the changes were in the autonomic changes were in the ranolazine group, sympathovagal balance decrease, but in the patients who didn't get ranolazine, it stayed above 2.5 and actually increased during the duration of the study. So now we know that we can increase parasympathetic tone with our alpha-lipoic acid. It's a natural substance. You can't harm the patient. And we know that you can decrease sympathovagal balance with ranolazine, which also has a remarkable record of safety. The outcomes in this study, 55 to 60% reduction in sudden cardiac death and malignant ventricular arrhythmias, and a 22 about a 40% reduction in congestive heart failure admissions. Again, sympathovagal balance was greater than 2.5, best predicted poor outcome. What would you do with this patient if a nurse brought you this electrocardiogram? Well, first, don't panic. The reason is, look closely. The coupling intervals between the PVCs and the normal sinus beats are variable, and there's fusion of the PVC with a normal sinus beat here. These are all characteristic of triggered PVCs, not reentrant PVCs. Remember that I said that poor gating results in calcium and sodium overload, which further result in early after depolarizations and late and delayed after depolarizations. Here's an example of an early after depolarization, which occurs before the completion of the action potential, single cell action potential, and that resulted in a 4-beat run of ventricular tachycardia. This was due to excess intracellular sodium and calcium. For delayed after depolarization, you need only calcium. Here are 2 catheter-induced PVCs followed by a delayed after depolarization that didn't reach threshold. In the middle, you have the same 2 catheter-induced PVCs that resulted in 2 delayed after depolarizations that did reach threshold. And so you had a couplet as a result of these 2 catheter-induced PVCs with a delayed after depolarization that didn't reach threshold. Well, it's easy to see that you can progress to ventricular tachycardia or ventricular fibrillation. So we found 59 patients who had triggered PVCs and gave them ranolazine. These were highly symptomatic patients with extraordinarily frequent ventricular ectopy. 95% responded to ranolazine dramatically, including a 91% reduction in ventricular tachycardia. And finally, in coronary disease, since that's involved with COVID-19, did a matched cohort study of 105 patients. They were very well matched. We won't go through all that. But what I want to point out is if patients who have events versus no events, with or without ranolazine, look at the sympathovagal balance and the CAN or AAD, 52.5% versus 16.9%. And if you even look within the ranolazine group, it's the same situation, 25.5% without event versus 35.2% with events. So the autonomic status, so in coronary disease, you get both. So in diabetes, you get parasympathetic. In congestive heart failure, you get sympathovagal balance. And in coronary disease, you get beneficial effects on both. And in this study, RAND reduced MACE in coronary disease by 63%, especially acute coronary syndromes. This is the first medication, this is the first study that has ever shown positive outcome data of any medication for angina. And once again, sympathovagal balance was critical in determining who suffered MACE. So, ranolazine and R-alpha-lipoic acid, I see no reason why they won't do the same things completely safely in COVID-19. I'm awaiting funding of my own study, but the patients can't wait. And so in a non-study, anecdotal fashion, I've been adding this to routine therapy in COVID-19. And I know I'm biased, but as far as I can tell, I'm correct. And I don't think this is so urgent. And this is so safe and it's so urgent. People are dying that I don't think people should wait until my study is completed and published. So in summary, then the COVID-19 virus attaches to the angiotensin II receptor, and that results in the two interconnected pathways, one indirect and one direct, and involving direct myocardial infection as well as blood flow impairment and acute coronary syndromes. Ranolazine and RALA will block the indirect pathways at two sites and the direct pathway here. As I said, I don't think these therapies care what caused the dysautonomia or what caused the congestive heart failure. I think the end result will be improvement in clinical condition and shortened hospital stay and avoidance and sudden cardiac death. So what I do right now is if a patient is admitted, I start them on 300 milligrams of RALA twice a day. If there's any evidence of myocardial involvement, then I'll start them on 500 to 1,000 milligrams of ranolazine twice a day, even if the patient is intubated. Although the package insert says don't crush ranolazine, That's just because it's time release. You can give the ALA because it's a powder, and you can take it out of the capsule and give it through NG tube. At the same time, you can crush the ranolazine and give 250 milligrams every 3 hours, all perfectly safely. Just don't use either one in severe renal disease. And because of that 1% per day mortality for 2 months, then I continue this regimen for at least 2 months at discharge. So coming back to the question that I intend to directly answer, and the basis of my study is the evidence I provided from those other studies. What do you think the answer is? I think the answer is going to be this therapy works. And the final point I want to make is the one thing we don't do as cardiologists incredibly, and it's in part because we're not trained in detail in the autonomics, and the Physio-PS monitor didn't become available until 2006, is I can't practice without it. And I believe it's vital that we know our patient's autonomic status, regardless, hypertension, coronary disease, congestive heart failure, COVID-19, whatever, ventricular arrhythmias. It's vital that you know the patient's autonomic status. We all should, and we should know that on all our patients. Thank you very much. That's the conclusion of my presentation, and I'd be glad to answer any questions if there are any.
It's a very nice and very well presentation because I am doing MPhil in basic medical sciences, and my area study about hypertension, and that area. There is a good presentation. If I'll, Dr. Guru provide me the link about their research and about their further work, then I will study their research work.
That would be fine if he would email me at my email, all small letters, DRGL Murray, MURRAY at hotmail.com, then I'll send him the PowerPoint presentation. And I would in turn like to ask all participants that if they go ahead and just add the RALA and ranolazine to whatever they're doing currently, so it's just off-label use. There's nothing really harmful, absolutely no harm can be done. If you go ahead and do that, which I think is urgent, then I would appreciate feedback if anybody would email me and say, and just tell me their experience with using both if they choose to do so, if they felt it does any good. That would be very useful in my trying to obtain grant money to complete the direct study. And I would be most thankful for your assistance.